Let's get started. The sooner we start, the sooner we can go to the beach. Good to see everyone. Thanks for being here. That was a great talk this morning. I guess what the key to memory is repetition. So I think Jubilee reviewed a couple of really nice things on rare tumors this morning, but I think we have a chance now really to take a deeper dive into the low-grade serous ovarian cancers. As you know, well, a couple of things. I've known Jubilee. We figured it out last night. I met Jubilee in January of 2001.
It's been a few years.
She was 15 at the time. and no, when I did my Felix Rutledge down there, and we had a good time. She was definitely a great role model for me, in a lot of ways, and particularly following her along her career, in some of the rare tumors. I learned a lot from her and how she interacted with Gershenson about how to get his ear a little bit to work with him, and I've been able to work with him a little bit on some of the low grade stuff. But really, it's most exciting. We got an FDA indication, right? We always said, what's the Holy Grail? The Holy Grail is to get treatments for your patients. How do you get treatments for your patients? You got to get them approved. How do you get them approved? You do studies, and you get the FDA to recognize it. And it's so exciting for, speaking for Jubilee and I, it's so exciting for us to be able to talk about an FDA indication specifically for a rare tumor like this, because it means we're able to do something, change the world. You got into standard care. So we're excited about that. And equally, on a beautiful Saturday morning in June, we're excited to be leading this educational symposium entitled Evolving Evidence and Treatment Strategies for Low-Grade Serous Ovarian Cancers. This is, a thanks to Jenna and her team, obviously, for putting this together. I'm really, I was just telling Jenna, I think all of these symposiums we've had this year, I think, Fadi, you and I, in our meetings on Sunday morning, we've already talked about how do we make this meeting a little bit more scientific. And I think, thank you guys really for putting the trust in Jenna and her team. But I think the ISS we've had, this meeting's really been outstanding. So thank you for you and the rest of the leadership. Obviously, Jason, you were involved with some of that. Marty, I'll just thank you. I don't know what you've done, Marty, but just good job, Marty. Yeah, but for the whole team, really. So thanks for that, and to have this industry-sponsored symposium. Jubilee and I are going to be working together. So again, I'm super excited. Whenever I have a chance to work with Jubilee, SGO president to be, which is pretty cool. And all the great things she's done for our career, for a lot of our careers. So it's great to work with her. Here's the required documentation here. More importantly, please, to get your CME credit, scan this QR code. I promise you it'll go to a real website and nothing inappropriate or anything. But at least not until it's changed. I caught Krivek one there going in my slides trying to put in like those links to weird. I'm like, Tommy, relax there. Next time. Here's our faculty disclosures. And they're all listed here, and they'll all be available. Here's our disclosure statements, and there's two speakers in this, but as I've learned, all the people on the CME committee who review these slides, their disclosures are listed here. Learning objectives. After participating in this activity, learners will have a better understanding of what the current competitive landscape is, what the new indications are. Really looking at some of the folate receptor alpha data, which is exciting. So this is specifically to highlight low-grade, an FDA approval in low-grade cancers, but low-grade cancers are considered under FDA approvals as well. So we're going to talk about that, some of the approvals that include low grades later on. What's next, including the future of ADCs and low grades, MEK inhibitors, understanding the KRAS mutated gene, learning and talking about adverse events and helping patients with adverse reactions and dose modifications, biomarkers and understanding first-line management of recurrent cancer. And really, I want to encourage us during the discussion. I really want at the end, because we have an hour and 15 minutes, but we'll have a lot to talk about a lot of things. But we want to hear a little bit about your experiences with managing some of the newer drugs and some of the maybe the pearls that we could share amongst our group. Here's our agenda. It's pretty straightforward. And obviously it goes without saying that this is an independently created content. All right, no one gave us our slides to use, but we're very grateful for the support from Veristem for supporting this educational activity. And it's two things: to learn more about, bless you, to learn more about their asset, but to learn more about the disease. And we can't learn about everything about the disease without having these type of symposiums. So thank you for Veristem for your unwavering support of what we do and helping our patients live longer. Without further delay, current competitive landscape and new indications, I want to introduce Jubilee, and we look forward to our talk. Thanks.
Thank you so much, Brian. That's from when I met Brian, that picture, when I was 15. So thanks for the kind words, and I'll just give some of that back to you. Like, it's been a really nice professional career. I feel like we've worked together in a lot of different ways over the years, and it's really exciting to see how you have changed the world and all the great work that you're doing in the GOG. So thank you. Thanks to all of you for being here. We had like a little teaser for low-grade serous carcinomas before in the last talk that you suffered through with me. So thank you. So we'll talk today some more. One like really important thing that I want to share first is that there are not a lot of pharma companies that will spend the time that Veristem has spent educating patients. And so one of the things when we talk through this is we now know a lot more about low-grade serous carcinomas, and so do our patients, and so do our medical oncology colleagues. And a lot of our job is really to educate people, patients, advocates, referring physicians, that low-grade serous carcinoma is completely different from high-grade serous carcinoma. And like in the last talk, I just flew through everything because there was so much to cover. But, now we get to do a little bit of a deeper dive into low-grade serous ovarian carcinoma and just talk a little bit more about how it is different and how we as physicians and providers need to be completely attentive to how we treat these patients. So I think, first of all, epidemiology, I remember back doing my fellowship, it was before there was a low-grade serous carcinoma. And, Dave Gershenson would talk with Anais Malpica about, how can we, there's something different here. And that was when there was grade 1, grade 2, grade 3, right? So as you look at the timeline, recognize that somewhere in the early 2000s, things changed for women with low-grade serous carcinoma. They were pulled out. And so as we see the change in time, the low-grade serous carcinomas, they're not nothing. It's 2,000 cases a year in the United States that are diagnosed. They used to be all lumped in and probably inappropriately treated. And so when we look at ovarian cancers and the epidemiology over time, we see sort of a slight decrease. And I think, why is that? Is that because the incidence is actually decreasing? Do we have better pathology? So now we have low grade versus high grade instead of just sort of a jumble of ovarian cancers. And, borderline tumors have also been sort of inappropriately categorized over the time. And so our pathologists really categorize these things for us much better than they used to. Serous borderline tumors, when we think about the different trajectories, and so I think everybody in the room probably knows, these different tumors are driven by different pathways. So, high-grade serous carcinoma, largely P53 driven, that's not what we're talking about. And that's really why low-grade serous operates via a different pathway. It's driven by a different pathway. It works differently. And of course, when we look at borderline tumors, why does that matter? It's because some percentage of patients with serous borderline tumors of the ovary eventually recur with low-grade serous. Very occasionally, I have maybe 2 patients in my practice that have a secondary high-grade serous component, but that's not the rule. They're driven by a different pathway. So when they recur as a low-grade serous carcinoma. And you can see the differentiating features in the table on the right that the age at presentation, we all know this, right? We see borderline tumors largely in younger patients. Around age 36 is the median. Low-grade serous carcinomas, age 54. And some of that may be because patients recur as low-grade serous after their earlier diagnosis of borderline tumors. Interestingly, borderline tumors are often associated with BRAF mutations, which may be protective against progression or recurrence as as a low-grade serous carcinoma. Only 5% of low grades have a BRAF mutation. I will say, interestingly, though, when we look at the RAMP data, that pathway of KRAS includes BRAF and NRAS. And so I think we need to look at this as we do a deeper dive into who should get what. There's been a lot of discussion, how should we stage patients with borderline tumors? And so it is actually helpful, I think, to still stage our patients with borderline tumors to see if we have any invasive implants, right? Because sometimes you'll have a borderline tumor that has an invasive implant of low-grade serous carcinoma, and you just have to know that. In terms of their clinical presentation, low-grade serous carcinomas are often bilateral, and we know how they look. They look kind of cauliflower-ish, which is one of the reasons I didn't eat cauliflower for a really long time. Really. CA-125s are often elevated in low-grade serous carcinomas, not as high as high-grade serous carcinomas. And again, like I mentioned, most patients are driven by different pathways, so they don't progress into high-grade serous carcinomas. We talked about CT imaging recently, and you all have seen this in your practice, right? So sometimes you'll have a patient with an advanced low-grade serous carcinoma. You treat them, the metastatic deposits, they shrink, but then you're left with these calcific deposits, and we see that as pneumoma bodies under the microscope. But on CT scans, it's really hard to figure out like what's active disease, what's not. That makes clinical trials really hard. And so going back and looking at those deposits, Amanda Fader and I are actually we talked about looking at this and seeing how do we describe these, because just like with immunotherapy, the radiologic criteria may be a little bit different for low-grade serous carcinomas, and how do we figure out if a calcific deposit has active tumor inside. On MR, you'll see sometimes papillary projections seen, and of course we see that when we look at the films ourselves. The treatment, of course, is cytoreductive surgery for low-grade serous, not so for borderline tumors. And we know we can even do a cystectomy for borderline tumors with only a 15% increase risk of recurrence as a borderline tumor that then can be salvaged. For low-grade serous, you really are not going to do a cystectomy. You're going to do a USO. The 5-year survival, however, is really excellent. So for borderline tumors, it's nearly 100%. For low-grade serous, though, this is important. The early stage patients do extremely well, 90% for stage 1 and 2, but 40% for stage 3 and 4. And hopefully we're going to change those numbers with what we'll share today. A few more important details. We talked about the pathway differences. And so for low-grade serous carcinomas, you saw this before, the pathway that is so important is that RAS/MAP kinase pathway. And so we can exploit that pathway with different targeted agents. I think that's the important piece. We talked a little bit this morning also about platinum sensitivity and how high grade and low grade, because they act differently, they're just not as sensitive to platinum agents. So, and this is what we see, again, boots on the ground, 4 to 20% response rate or platinum sensitivity rate in low-grade serous, compared to what we see where in high-grade we give neoadjuvant chemo and within a few cycles everything just shrinks down. So I have enough time that I'll digress a little. When I was at Anderson, I had this lady, she was in her 30s and her husband was a firefighter, and she came in massively distended. I'm like, it's okay, you're going to respond to chemotherapy. And she did not. And of course, it was low-grade serous carcinoma, and that was before we knew very much. But I said, well, let's try letrozole. Literally within 3 months, shrunk down. She's still doing great. And so that just speaks to the kind of the difference in pathways. So when we look at the histopathologic comparison of low-grade, high-grade, and borderline tumors, when we look at low-grade serous carcinomas, you can see this uniform population of cuboidal or columnar cells. They're not borderlines, they are invasive. So you see stromal invasion, usually with some atypia. And you see much more of that branching, beautiful tree kind of pattern. I'm not a pathologist, but I would call it the beautiful tree. You see psammoma bodies prevalent with small, consistent nuclei. For high-grade serous, they look angry. We know what they look like. They look terrible. High-grade nuclei, large, atypical, with a lot of necrosis present. Borderline tumors, by definition, are not invasive, and we should call out. However, there's this like interim thing, this micropapillary subtype that tends to do a lot worse, and so it's really important for our pathologists to be able to describe this for us. I also just from a from a how do you explain this to patients situation with borderline tumors, I think that's important, especially for the trainees in the room. So everybody explains this a little bit differently. So when I talk with patients, I'll tell them that, when I think about benign, I think about something that never comes back. You take it out, it's gone. They don't respond to chemo, and you don't need chemo because once it's out, it's gone. With a high-grade tumor, it's kind of the opposite. Aggressive, comes back even though you take it out. Borderline tumors, it's not that the diagnosis is borderline, it's that it acts differently, right? So it's neither benign nor high-grade cancer. It can recur even though you take it out, and when it recurs, it can recur as a low-grade carcinoma. We know now that for NCCN clinical practice guidelines, there are lots and lots of different options, and still, we haven't really separated out everything. However, low-grade serous carcinoma, as you can see, is separated out some, and we have carboplatin paclitaxel every 3 weeks, plus or minus maintenance letrozole or other hormonal therapy. We'll talk more about that, and hormone therapy with other options recommended in other circumstances for stage 1 disease. This we talked about this morning a little bit, but it's worth a deeper dive. So this was Dr. Fader's trial, NRG GY019, where we had patients with stage 2 through 4, biopsy-proven low-grade serous ovarian carcinoma. Very important that tissue diagnosis, not just cytology, was required. These patients, by definition, had to be p53 wild type, again, because it's different pathways that drive these tumors. They had to be of decent performance status and have had an attempt at maximal cytoreductive surgery with no prior chemo, stratified by residual disease status and by country. Arm 1 was paclitaxel carboplatin at the standard doses, noted carboplatin AUC of 5 for 6 cycles, followed by letrozole. How long? Until progression or toxicity. And arm 2 was the goal, of course, to eliminate chemotherapy. So just letrozole, not just for 6 cycles, but also until disease progression or toxicity. Very important, the primary endpoint was investigator-determined PFS. Looked at other things like safety and OS, but really PFS was your primary endpoint. And here we have it. So statistics are important. Can you put your thumb in between those curves? If you blow it up big enough, yes. But there's honestly, when I look at those curves, at least long term, at first when I looked at this, I'm like, well, I don't believe this. There's not much difference. But when you actually dive into the statistics, and keep in mind this was a non-inferiority trial, so 77.9% of patients on the combination and 71.9% of patients on letrozole alone were alive and progression-free at 2 years. Remember, this is an indolent tumor, so looking at things like PFS or overall survival are really hard because it takes a really long time to do this, right? So, their primary endpoint, though it was PFS, at the time of interim analysis was the percentage of patients progression-free at 2 years. This hazard ratio calculated from that basically showed that this trial at hazard ratio of 1.3 with a basically didn't allow for non-inferiority to be determined. There were pre-specified confidence intervals, and so this basically was outside those bounds. So we cannot call it non-inferior. Okay. When we pull out subgroups, subgroup analysis is everybody's nightmare, right? So the subgroup analysis looked at patients who had no residual disease at the end of their surgery. Because again, like we talked about this morning, this was surprising to all of us. And it doesn't quite make sense. So do we think that there's a difference in patients? Because there were really two big groups of patients here. One group that had a ton of disease and one group that had R0, right? So is there a difference? Well, it looks like there may be a difference. And if you look at the PFS subgroup analysis, the recurrence rate on the group who had letrozole with disease residual, so like the worst prognosis group, had a much higher risk of recurrence, 41%, compared to the group with no gross residual. I will draw your attention, though, to the fact that when we look at this, that no gross residual group was a lot more. There were 142 patients in that subgroup compared with 82 in the group with residual disease. So is it possible that the group with residual disease is potentially driving the worst outcomes? So, this is the thing, this is exploratory. It's not definitive. And so I would suggest that I don't think that we can say that you can use letrozole alone in this subgroup yet. And we'll look for sort of more mature data to come out with that. Adverse events, it would be sort of what you would imagine. Letrozole is certainly much more well tolerated than paclitaxel carboplatin. No new safety signals. So when we jump forward and we look at clinical practice guidelines, so NCCN guidelines, essentially what's going to be reflected for low-grade serous carcinoma is going to be paclitaxel carboplatin followed by letrozole, not letrozole alone. Let's talk about recurrent disease. So when we look at recurrent disease in low-grade serous carcinomas, there are things that are approved now and listed. So hormonal therapy, fulvestrant for low-grade serous carcinomas, and avutometinib defactinib for KRAS mutated patients, and trametinib all comers. So let's go through those data. So in the recurrent setting, we're going to focus first on the MAP kinase pathway. And again, those mutations really drive low-grade serous carcinoma. What we're talking about is KRAS, NRAF, and BRAF, highly present. The first trial to talk about is the MILO trial. So this is the binimetinib trial. Again, for patients with recurrent or persistent low-grade serous ovarian carcinoma, comparing binimetinib with physician's choice chemotherapy. And what do we see here? So when you look at the response rate in KRAS mutant and KRAS wild type, the KRAS mutant, as you might expect, have a 44% response rate compared to a 19% response rate in KRAS wild type. That's important because what we see is not a lot of difference between these. It's kind of small on here, but if you look at the PFS on the left, Kaplan-Meier, what you end up seeing is the median PFS is 9.1 months compared with physician's choice chemotherapy of 10.6 months. So you would think no difference, right? But then if you pull out the KRAS patients, it looks very different at that 44 versus 19%. So though this was a negative trial based on the way it was built, the information that we got from this is actually important because it highlights the importance of looking at KRAS in these patients. So it's really directed therapy that becomes important. So this was Dr. Gershenson's trial, similarly looking at trametinib versus standard of care. And you can see these are way different curves than these curves, right? So why is it that binimetinib didn't seem to work, but trametinib did? And we think for a couple reasons. One is, going back, binimetinib didn't pull out the KRAS mutant patients. And here, the trametinib, the patients who receive standard of care seem to do better than we would have expected them to do. Look at that hazard ratio, actually. It's 0.48 here in the trametinib group. And that may be because the binimetinib group, the standard of care, did better. In any event, trametinib showed an improvement, and this demonstrates the efficacy of MEK inhibitors. So we also see that play out, interestingly, in not just median PFS, but there is a a signal for overall survival, 37 versus 29 months with a hazard ratio of 0.75. Didn't reach statistical significance in terms of overall survival, but that may be related to the natural history of the disease. Probably, I would say the most exciting thing that's come about is the utility of avutometinib and defactinib in recurrent low-grade serous carcinoma. We skimmed over this morning, but just to do a deeper dive, this was really, I would say, a hallmark study because it looks at two drugs that not only treats the pathway of interest, but blocks the escape hatch, right? So these are oral drugs that tend to be well tolerated, and we'll show you how that works. So for RAMP 201, this was a multi-part trial. Keep in mind the way that these drugs are dosed. Avutometinib is 3.2 milligrams twice weekly. Defactinib is 200 milligrams twice daily. As you can see, there were other areas of this, like Part D looks at a lower dose in combination. The mechanism of action, as we've alluded to in the past, avutometinib inhibits the MEK and RAF by stabilizing the MEK-RAF complex. So basically, it's a clamp that happens right there in this, on the left side there. And the escape hatch then is blocked by defactinib as a FAK inhibitor. And so when we look at the results here, the first RAM 201 looked at the single agent avutometinib that you see on the right, compared with the combination of that avutometinib and defactinib. And what we can see is here these patients were largely equivalent, so no differences here that would explain any differences in outcome. But when we look at the difference in outcome, it's pretty impressive. So the avutometinib, when we look at overall response rate on the right side, for all patients, you get about a 17% response rate, whereas with a combination, you get a 31% response rate in all comers. When you select that out for KRAS mutated patients, it's up to 44%. And look at that. Some of those patients did have complete responses. Also important to look at in any, even though this wasn't the primary endpoint, it's important in any disease process with that's indolent to look at the clinical benefit rate. So basically, when you add up the response rates, complete and partial response and stable disease, you get an extremely high, look at that, only 8% of patients progressed. That's amazing. So that really helped to establish the utility of avutometinib and defactinib as a combination therapy here. And when we look at the waterfall plot here, we can see in the royal blue, the KRAS mutated patients, how well they did. These are really significantly deep responses. But also interestingly, to your point, Donna, earlier, patients who had KRAS wild type also did respond. We don't have the indication for that yet. We only have the indication for KRAS wild type, but stay tuned. We'll see with RAMP 301 how this progresses. So what we obtained from this was an FDA accelerated approval, May 8, 2025, for avutometinib 3.2 milligrams twice weekly and defactinib 200 milligrams twice daily in KRAS mutated low-grade serous ovarian cancer. So amazing. These are oral agents. I will tell you they work quickly, and we can talk about this some more, but I've had patients who literally after 1 or 2 cycles, NED, there's nothing. Their CA125 is normal, their CITES goes away, there's nothing left on scan. I've just personally done dose interruptions for a little while and then dose reductions. You can keep these patients on for a long period of time and they tolerate it extremely well. What does that look like? In the study, one thing that's important to recognize is increased blood CPK, which tends to not really affect anything other than physician anxiety. Everything else, we know how to handle. And so, yes, we see some diarrhea. Yes, we see some nausea, but those are things that can be easily managed. We see them a lot worse with many of the other drugs that we use, because when you look at the grade 3 toxicity, it's low. It's 3 to 8% nausea, vomiting, diarrhea. So we do see occasional blurred vision. And again, We know how to deal with that now. So again, the important points here, I think 80% of patients had AEs leading to dose interruption. Of those patients, 38% had elevations in CPK. But does that end up leading to anything clinically? Generally not. 36% of patients had AEs leading to dose reduction, but only 10% of patients discontinued for AEs. So, and most of the patients, it was for the CPK. So I think that speaks to, yes, you can have some side effects, but based on dose interruptions, just breaks in therapy, like let them go to the beach for a week, it's fine. And dose reductions, you can get them through. The ocular events, again, these are mild and they go away over time. We don't see pneumonitis with this. We don't tend to see hypertension, and that worry about CPK, you can see it really doesn't impact ejection fraction or congestive heart failure. So, this has been a ctDNA conference, and so looking at the RAMP 201 samples, a couple of, I think, really important points, and kudos for looking at this, because the more information we can get, the better. So there was 44% concordance between tumor and blood samples. And so 56% of them showed a false negative rate from ctDNA testing. So basically, it just didn't correlate one-to-one. And that's weird. That's not what we had expected, right? Interestingly, also, there were no KRAS mutations detected by ctDNA testing in patients with KRAS wild type in tumor samples. So we knew that that correlates. But basically, these are low-shedding tumors. So low-grade serous carcinomas, by and large, are low shedders. So you may not be able to rely 100% on your ctDNA for prediction in this tumor type. So I think in conclusion, our clinical trials, as we've seen, and this has been, like, honestly, just personally, I'm so grateful, because we've spent our lives dealing with rare tumors and really haven't had a lot of trial uptake until recently. And it's because of the GOG and the NRG and everybody who enrolls patients on these trials that our patients with rare tumors actually have seen this much progress. And thanks to industry as well for believing in rare tumors and thinking that all those patients are important, because they are. Clinical trials changing the treatment landscape for advanced low-grade serous carcinomas. We now have systemic treatments for low-grade serous carcinoma, way different from just a couple of years ago. And avutometinib and defactinib combination in KRAS mutated recurrent disease is the first approved therapy in low-grade serous ovarian cancer. It has FDA accelerated approval, and will look for the long-term data there and for hopefully all comers, not just KRAS mutated patients in the times to come.
Hi.
Thank you very much, Matt O'Brien.
Thanks. That was great. Thanks, Jubilee. Yeah. I think that was really fun. We're going to keep talking about this. It's really fun to see what we've done and where we're able to get this with approval. I think I'm going to go through my slides, but I think one of the things, I think the discussion will be fun to talk about, just to give Jubilee a chance to think, and maybe others. What should our next first-line therapy be? What should our next first-line study be? Well, let's think about that as we go through what the next are.
I think I have an answer for you, but
well, let's see if it's the same as my answer, but I'm sure yours is better than mine.
No, yours will be right.
So what's next in low-grade cancer treatments? So here's some of the emerging therapies for low-grade serous ovarian cancers. We're going to go through some of the scientific rationale to explain the 201 results, talk about the confirmatory trial, which has accrued. We're waiting for that, but as you know, with accelerated approval, you can get the drug to your patients, which we're doing. It's the confirmatory trial that's required to maintain the long-term use of the drug. We'll talk about some of the second and third generation antibody drug conjugates and some of the data there. Really not to focus on that too much, but those trials have or can include low-grade serous, so it's important to talk about the potentials there. Some of the other studies, the NCI match EAY-131 subprotocol H, dabrafenib and trametinib in the BRAF tumors. We'll talk about 3026, which we published this year, it's been mentioned. And then trials in the upfront setting and where we can maybe go to next. So let's highlight some of the treatment of recurrent low-grade serous ovarian cancers. Jubilee showed this nicely. This is a mechanism of action and the vertical blockade and the parallel inhibition. of the rationale of why defactinib and avutometinib work so well and so nicely together. The trametinib and binimetinib, it does work well. It does work well in the mutated patients, but you can see it's one blocking the pathway, not this parallel inhibition, which we presume the dual blockade without head-to-head studies, but it seems to be a more comprehensive approach of blocking and exploiting the nuances in this pathway. So this is the confirmatory trial. This is the trial that was open, that you accrued to, all right, and that we closed, and that we're waiting for these results to confirm the results of the accelerated approval. Confirmed diagnosis of low-grade recurrent disease after prior platinum therapy, documented KRAS status, whether wild type or mutated, prior MEK was allowed, prior BEV was allowed. Stratification factors are shown here, KRAS status, number of prior lines of therapy, 1 to 3 or greater than 4, geography, geography, whether it be North America and Europe versus rest of the world. The treatment arms are shown here, avutometinib and defactinib, 135 patients, overall almost 300 patients. And the investigator's choice included liposomal doxorubicin, paclitaxel, or one of the AIs, letrozole and anastrozole. The study also did allow for crossover. So if, from the standard of care arm, they failed, they were allowed to go over to get the avutometinib and defactinib. Primary endpoint here is progression-free survival, relying on BICR, sequential evaluation of PFS, first in the KRAS mutated group, and then the all-comer recurrent group. Right, so it's not two separate studies, but statistically they're looking at the KRAS mutated group first. Now, if that's negative, the study's over. There's no alpha that goes to the all-comers. But if that's positive, then the stats will assign alpha to the rest of the group to see if it does work in the all-comers. To Jubilee's point, hopefully maybe it is a drug that can work in all patients, not just those with the KRAS mutated. The secondary endpoints are shown here. So that's just, that study's the one that we're going to wait to read out, hopefully, and it'll read out sometime in the near future with positive results. Here's just a picture of antibody drug conjugates. I showed this picture here because there are such nice pictures of uterine transposition. They made fun of ADCs, so I figured we make some pictures of ADCs to compare. Scott, when you make a family album of the meeting, maybe you'll throw this one in there as well. But you guys know the three components: the antibody, the anchor to the cell, the kill, the payload, and the linker, which is the most important part. And here's some of the data, looking at the Soraya data, Forward 1 data, and the Mirasol data, looking at the results of mirvetuximab and ADCs. And we know these results, and this doesn't break it out by low grade, and we know the positive results and the impact. The important point here that I want to highlight is we do have another FDA-approved drug for low-grade serous ovarian cancers, and that's mirvetuximab. The label allows for using mirvetuximab on label for low grade, so it's important there. And we've used it in our practice. I've used it in practice. I've seen it. Santine's done a lot of work on this out of Yale. He published something in the International Journal, and Rob and I wrote an editorial about it. So there's definitely a role of exploiting the alpha folate receptor pathway in low-grade serous ovarian cancers as well, and we know this data. And that's what showed here, that this approval does allow for use for all comers with ovarian cancer that are overexpressors. Here's another exciting ADC, and again, not going to highlight this too much because a lot of this data is based on the high-grade data, but the RENA-S data has US FDA breakthrough designation for endometrial cancer, fast-track designation for variants of ovarian cancer. Here's the study design of the Rainfall-01 study with a dose escalation, dose expansion, looking at the different dosing levels. And we could see here from the anti-tumor activity, it's active in ovarian cancer. 50% response rates in the 120 milligrams. Again, not to focus on too much for the low-grade aspect of this talk, but just to say there is still a rationale. And as we're further discovering the best ADCs for cervical cancer, endometrial cancer, high-grade ovarian cancer, we still have to study and look for the best ADCs because it's definitely an area that we could exploit as we move forward. Last but keep going through this list is the BMT, the BioNTech 325, the TROP2 ADC Biduality and BioNTech. Similarly here, there's response rates in this pathway looking to target TROP2, which can also be seen on these low-grade tumors as well. This is the NCI match EAY131, looking at targeting for the BRAF mutations. Here's a list of the, we could see from the waterfall plot and the swimmer's plot here, the GYN tumors are in royal blue, and we could see that their responses here to this combination of drugs that did have the BRAF mutations, which the relevance here is, yes, there's a lot of these low-grade cancers will have these mutations. So looking at these results, there's maybe an opportunity here to further exploit it with a combination of the dafitinib and trametinib. It's interesting, with a trametinib definitely does have activity. It's going to be tough for us to do head-to-head trials, but that's always going to be the question. Do you need these combinations, or should we go back to the trametinib that we showed in 281 that was an active regimen? This is an area, just to give a little story, sometimes we always talk about how trials come to play, things like that, how you get involved in something. With the CDK4/6s, this is something we looked at a long time ago. Actually, when 281 was finishing up, and there's a problem with it, it was a non-registrational trial. They're very, very, very poorly funded. Okay, so when 281 was closing up, a lot of people don't know the story. They ran out of money. The reason why they were running out of money is because there were too many patients allocated to be accrued in Europe, in the UK, and they didn't have enough patients there. So then at the time, Gersh and I went to Novartis, which had acquired trametinib from GSK at the time, and we said, we need more drug. And they said, all right, we'll do more drug, but can't you do something for us that maybe we can go for a regulatory approval in your setting? We said, yeah, give us more drug, trametinib. We did. We finished that study. But then we said, yeah, let's look at your CDK4/6. It works in breast cancer. Low-grade serous ovarian cancer, I haven't said it yet this meeting yet, but low-grade serous ovarian cancer is breast cancer, guys. It affects the ovaries, but you treat it like breast cancer. And if you think about that, you'll treat it better. So we came up with them. We said, great, you guys have ribociclib. Let's use your drug, combine it with letrozole, and look at it in low-grade serous ovarian cancers. And then, all the enthusiasm, yeah, let's do it. We'll get data, get regulatory approval. They're never going to go for registration, but that's how we sort of started the conversations of doing the ribociclib and letrozole for recurrent low-grade serous ovarian cancer, GOG 3026, open label phase 2 activity trial. All comers in these patients, investigator-initiated trial. This is a plug for to highlight, not a plug, highlight the ability in the GOG also to do IIT studies. They're not free. The GOG doesn't pay for all these. All right, this one came in from funding from, and I think Cope was the president and Tom carried over it, but was the president when we signed on this. This is money comes in with it from the industry, so Novartis paid some money, but it doesn't cover nearly the costs. So it's not going to the GOG with nothing and saying, here, I have an idea, let's run it. It's saying, oh, here, we have an idea, it's coming with some funding, but we need help with your sites and some operational aspects and things like that. And that's how we push this through the GOG partners mechanism as an IIT. Couple things to highlight here. The response rate's 30%. All right, when I presented it at SGO 3 years ago, the response rate was 20%. Accrual is closed. It highlights the mechanism of action of these drugs. The slow in the tumor, they're not cytotoxic drugs, they're cytostatic drugs. So you see your responders, but you see them over time. All right, so when everyone says, well, why did it take you 2 years to write up? I mean, I'd like to say the truth and say I'm a procrastinator, but the truth is actually we saw the benefit of the drug continue. The response rate went from 20% to 30% without doing anything. That's how these drugs work. You see the long swimmers plots. The two curves there, one's PFS, one's OS, but it was a really active regimen and 30%, right? So Jubilee went through some really good data. KRAS positive, 44%-ish. KRAS negative, 17%. So it's funny, now we're in this weird time of all these drugs are coming out and all the, everyone's interested to hear our opinions. And they say, well, which one are you going to use? Which one's going to win out? Which one's going to... It's not which one's going to win out. It's our patients are going to win out because we have more options for our patients. What we need to figure out in rooms like this is we need to figure out how we're going to sequence them, right? But because I saw, and why am I saying it like this? I saw one of these, someone once sent me slides that it said, Slumbits, they're really attacking 3026. In this marketing survey, they're telling people why they shouldn't use your regimen. They should use, the lunametinib defactinib. Yeah, use them, but it's not one or the other. It's we have other options for our patients. which is the message we as practitioners have to tell the companies when they come to us. You know, we're not having a B96 Rosella conversation, but we all win when there's two. It's not one or the other. We all win when there's 3026 and when there's defactinib for the low grade. So, but really, good data, 30%. It definitely falls into the more activity for the patients who suffer for this disease. So first line therapy, options that are ongoing. This is a study that's being led by Rachel. It's a really nice trial. Combination targeted and hormonal treatment of low-grade serous ovarian cancer in the upfront setting, the Chameleon trial. This is for patients who had unresectable low grades with no prior treatment, or patients with suboptimally debulked disease. They have a radiologic assessment of tumor, treated with avutometinib and defactinib with letrozole, radiologic assessment after 3 cycles. If they had unresectable disease, they get 3 to 9 cycles until clinically appropriate for resection. Or if they have progression, they're off trial. Then if they can get resected, interval debulking followed by 12 cycles of avutometinib, defactinib, and the maintenance letrozole. For those that had suboptimal debulking, patients with clinical benefit get up to 21 cycles of the combo of avutometinib, defactinib with letrozole, and then maintenance letrozole. And if they get, if they progress, they come off of trial. This is an exciting trial, and we'll see how. I think this is going on at Sloan and down in Emory, right? Of course,
I think it's just
Barrels brought up. Yeah, it's good. It's a nice trial. It's nice to do prospective trials in this setting. Then there was the Bouquet trial, and here it's a closed trial. The key to presenting this, it's a rare tumor study. Jubilee had a lot. I want to again shout out for Jubilee, had a lot of leadership in this trial. A rare tumor trial. You don't always do like one study for a rare tumor. This is an example of a basket trial. So you could see all the different arms that they had. The sites that had it really had one study for a lot of different tumors. You could see here some of the different arms that were investigated. They looked at the cometinib in the BRAF KRAS mutated group, ERB2 amplification. We're waiting for the results. Hopefully the results will come out soon. But really jumping point of doing some of these large basketball trials for tumors with multiple different mutations. The other one study that I took the slide out, or I forgot to put the slide in, is Lauren Cobb and Gershdown and Anderson did a neoadjuvant trial looking at abemaciclib and letrozole in a neoadjuvant setting, and they had a pretty high response rate as well. So let's talk about adverse events, but I tease in, what should, you presented GY019, right? And it was a negative trial. Is there a detriment of not giving chemotherapy? Either way, it didn't meet its endpoint. What should our next first-line trial be? What are your thoughts?
So I have thought about this. So I think, first of all, I really like the Chameleon trial. I think it's going to answer a lot of things, but the control arm is letrozole.
Yep. But now we're going to do a free ad board for industry. We're going to come up with your trial. And
so I think that given 019 results, the thing that would be most meaningful is to do avutometinib, defactinib, followed by letrozole, compared with paclitaxel, carboplatin, followed by letrozole. You'd have to figure out if you wanted to risk a negative trial for all comers, or if you'd want to restrict it to KRAS mutant patients. And so I think for patients that would potentially benefit because you could skip the chemo up front and establish an oral regimen up front for patients.
Yeah.
So this trial, so would you say this is hepatic disease? So remember how you can diagnose the lady that you teach BSO has 1 centimeter of bed, PMS and nodes. Are you going to give her carbotaxol, or are you going to give her less?
Good question. What are you going to do?
Tell me the patient again.
So she's up to do a microscopic, not a lot of C's at TBSO, 1 centimeter or less, low rate serous. According to the GG Shrapel, she carbotaxol, letrozole, except with such analysis, but
Well, I agree. And I mean, so that's why the trial like that just kills me, because I feel like it's really hard to generalize that to everybody. I mean, if you're like a strict rule follower, you're going to do paclitaxel, carboplatin, followed by letrozole. I think it's a negative non-inferiority trial, and I know Wendell, you're jumping up and down back there. But I think it's hard to generalize that to everybody. Reality.
Other thoughts, Wendell, and then
Take a couple things. So a negative, inconclusive non-inferiority trial does not imply superiority.
correct.
So we can't. The only thing we can say about these two medicines is we can't guarantee that letrozole is not inferior.
Is not right. So many double negatives there.
Everybody in this room does minimally invasive surgery for endometrial cancer. Okay, so a lot of people don't know the MAC 2 with the non-inferiority trial, it did not meet its non-inferiority endpoint. Why? We do because we figured it's close enough.
Well, so the question though is 1.3 hazard ratio. Is that close enough? And I don't know.
1.3. That's the median. The top zeros cost more. And as you look at those data, I mean to look at the statistical analysis. It's heavily censored in that. You have to remember we have a heavily censored Kaplan-Meier curve. You put a overemphasis on the early part of the curve where they separate, and then they come back together. And at the end of the day, really, it's survival that, does it really matter that there's a 9% increase in PFS at a year and a half or 2 years or wherever that bubble is? At the end of the day, it's how many patients are allowed. And it's also the toxicities from our treatment. So I think we do have to remember that. And as we cancel our patients, that's important. And we put a much higher emphasis on, quote, the best Serous, but it's also, you have to patient per count. So you're going to create permanent neuropathy in the patient. They're going to lose their hair. The long-term effect of chemotherapy.
And they're going to feel horrible for a long time on this therapy.
That was the kind of comment that this is a non-inferiority trial coupled across to one. And what I'm having a hard time understanding why general consensus across community is like, oh, we have to go back to arm text. In my mind, it does absolutely just ways that study that should do your right plus. This is your idea.
If hormone therapy had been the standard of care,
Evo was never impacted, and then I should have been a superiority for its chemo equivalent because it's more high. Exactly. So that was study decided. I would imagine that chemo is superior to letrozole, and that's an easier trial to run, less patients. And hey, that take the advantage that the hijack instead of the second kind. Which is the other thing I have a hard time is you're right. So the hex of this, especially for RAM.
I really have a hard time understanding why they exclude that from the control arm for these studies.
And from my discussions, like even looking now, we all accept are we the carboplaxol or are we the electrical? And we know that low grade here is the highly antigenic, and you know the anti-antigens and the significant improvement, not improves outcomes, and you know that based on ends there, I think, and then slow did as well. So all these trials experience Avastin from the control arm, and they get around by saying prior what or allowed, which we don't have that. So for high grades here, I mean less determined, we insist upon as scientific to that, but low grade.
Yeah.
Yeah, I mean, it's just. Oh, well, you go first.
Well, I mean, I was going to say, I think it's when you are designing these trials, there's 15 different versions that go around, and like it ends up trying to make the cleanest trial to answer a specific question. And you're right. The reality is that does have a significant, benefit in these patients, we think. But then we get into okay, so how many questions can you answer in a single trial, right? So I don't know, what's your thought there?
I mean, I have a simpler answer. Listen, I think the reality is the companies we work with are obligated to help us come up with better treatment options for our patients, but they're also looking to increase their chance of technical success. Bev is a great equalizer. If you put Bev in the control arm, you could lose.
And that's 100%, and that's absolutely why you do that. That being said, if you lose the negative.
No, I'm not. and maybe you can't. I'm not minimizing your comment. Off trial, 100% I would do that and odd for prior. And you could have that strong stance and say, I'm not going to put a patient on trial because I can't do it, which is okay. But yeah, we want to do what's best for the patients, and we got a good accelerated approval, but you can't get the drug to, and what's another example of this? And I'm not calling them out. I'm giving an example. Rosella required prior bevacizumab. Why did they require prior bevacizumab? Because it's a later line therapy, but you don't want to go against it in the control arm because you could lose. And I have no animosity towards the company for not doing that because you got a new drug. But if and we're studying it now in the Bella trial, we're looking at the combination of bevacizumab. But in the Rosella trial, if bevacizumab was in the control arm, we may not have the opportunity to give our patients that drug, which we know may be active. Not the right answer, not the best scientific answer, but the reality of the situation. So here's my study. My study is to do a first line study for the, what's that for the, let's see what, it's okay, Tommy, I don't know. This is my idea. This is my idea. It's my study now when it doesn't exist. Later on, it's our study. I have no problem. I'm sharing. I'll share the blame with you as much. Tommy and I came up with this idea last night at the bar. Tommy and I were drunk at the bar last night. We said in the mutated group, give him the combination of ivumetinib and defactinib. In the non-mutated group, give him ribociclib-letrozole. All right. Versus carboplatin paclitaxel with letrozole. You give letrozole in both maintenance group, in both maintenance arms. Okay, so then based on the historic
This tells me
data,
I should never have gone to bed. I should have gone to the bar and had that conversation.
yet another example. So in the mutated group, you're relying on the 44% data. In the non-mutated group in the second line, you have the 30% data. And then the beauty of this trial, I'm saying this, I've already said this to the Verastem people, and they're not buying into it. But the beauty of this then, in the two arms, once they fail, allow crossover of the two treatment arms. So when you fail the ribociclib-letrozole, then get your prospective data of ivumetinib and defactinib in a non-chemo setting to see what it works, because we want to get an all-comers approval. And the same thing in the mutated group, when they fail, give them ribociclib-letrozole. Tommy, thoughts?
From this trial, we should have a good idea about KRAS. KRAS is going to be like, it's mutated, BRCA mutated, HRE positive, and KRAS wild type, HRP kinase that really need to look at those differences.
Yeah. The KRAS aspect.
All to me is walking surgery and then molecular analysis.
Chameleon's a great study.
I just wonder, are they gonna have to go back add carboxyl to the letrozole for FDA?
I wondered that too, actually.
Yeah.
Now that
Did you do this trial and have the FDA come back and say, are they gonna
There's no real accepted control arm for first line in this setting. All right, it's what the FDA will say. Yeah.
But yeah, it depends on which study, but historically it's been really low, like 20% or less. Well, because it outperformed in the studies of reference here. So
well, did you with high grade probably? GG182 was all 1, 2, 3 in the LVAD.
yeah. Well, and so right. So I think Will and some others have pulled out those data, and yeah, they certainly don't do as well.
Tongue.
You also sure that we have the STAT3 receptor? Are we looking to target that?
Not that I'm aware of, but we can. I don't know what to stay on.
Sounds exciting.
What about PARP inhibitors? I bet, is there an arm? Ivermectin. I mean, I've already taken a shower with ivermectin this morning. I'm going to have it. I put some powder flakes on my lunch for it. So what else am I going to use ivermectin for? I haven't looked at ivermectin since I'm not. No, I haven't. But talking about KRAS, the KRAS, since that pancreatic paper came out, 5 of my ovarian cancer patients call me up and say, "Do I have KRAS summary mutation?" So you could educate. You could definitely educate. I bet. What about PARPs in these patients?
I love the rationale, but KRAS mutant, all KRAS, because all the KRAS mutants are so selective and collaborate together. And it was low grade and poverty, like the responses we see here. True factality is data, but because the straw so low, but combination of PARP is a
I think the question is going to be, what is it versus MEC alone? We don't, we don't know. So, all right. So let's, so we talk, so there's ideas. We do need to have a first line trial. The combination, is it going to be a pharma-based trial from the Vericem like folks? Is it going to be an NRG trial like GY019, some sort of combination?
We're working on 019. We should chat.
Yeah, no, that'd be great. So what about patient effects? Jubilee, and you went through the data nicely with some of the adverse events and things like that. In the last couple of minutes, talk to us about some of the pearls you have as far as starting the patients and keeping them on through some of the common side effects you may see.
Yeah, sure. So I think biggest thing is Miranda. So she's our PharmD, and she educates patients very well ahead of time, so that they know how to prevent nausea, diarrhea, manage eye toxicity. And she spends a lot of time. She spends a good hour with every patient before they go on this. The other thing is like dosing, and that's not quite adverse effects, but twice weekly is not a typical dose. So have to make sure that patients understand that. And then we make sure that patients can really follow up with us through our nurses, through our portal, through the PharmD, through our PAs, just to make sure that we connect in early before they get really sick. And usually, these are things that you can reverse. We like I say, we have experience with all of those things, whether it's ocular toxicity, nausea, vomiting, diarrhea. The CPK thing is the one. Just the CPK thing is the one thing that is a little bit of a challenge in terms of everybody panics, and it doesn't seem to really be much of anything. Yeah. What are your thoughts?
No, from the audience, anyone who's been using the combination that had any pearls to educate us about, or anything they're worried about that we could discuss? Any thoughts? Scott, you've used it, right?
We don't.
KRAS mutated patients.
To lower as they floating around, and all they're like just totally land.
Anyone have experience using it in practice? Wendell, any thoughts?
rash. So I just spoke with the rep and I got a recommendation for the doxycycline and the capsule stuff at the rash.
Yeah, I will say, and it's not because this is sponsored by Vericem, but the reps have been very, very supportive for this asset. I mean, they're available for a lot of things like that. But
The one patient we had in our practice, one Parker's patient, the first week she had a red blood death.
Whoa.
It's reversed, but we never there.
of course not.
Yeah.
I haven't heard of that. I haven't heard that
Me neither.
as much. Tommy?
Eye doctor, but I already from the eyeball, bad the eyeball. This to that, but it resolved, and she went back on. She actually had a complete response. Her biggest side effect was just teeth, and so she came on trial, not for regression, for side effects of teeth, and we're waiting for the approval for on the order.
That's what happened with my lady.
Yeah. She would stay on long term, but you can't do that on trial. You got to be regimented. It's so how we classified it was for fatigue, bigger spots. But I was surprised about the recipe capture that happened right away. If she had a rash or a milk attachment, just like and she got fit. She didn't want to stay to see him. Yeah, so she stayed on, and that's no less pre-diagnosed by omit regular catch. You insert net fixes surgery.
Interesting. Scary, right? Scary.
Yeah.
Yeah, but that happen all the time. Yeah.
Interesting.
Other thoughts? Any other questions?
So the ribociclib letrozole, I didn't accrue that trial because all my patients progressed on lenizole.
Great question.
Second line, is there any data, or has anybody used this after, maybe with a break on another line in the middle after letrozole? Is it still efficacious?
Yeah, that's a great point. That was one of the limitations in the trial. When we wrote that trial, it was before, I would say, the landmark Gersh paper that came out about maintenance letrozole. So we were still expecting to see letrozole naive patients. During the course of the trial, we decided not to change it, and we left it as is because based on all of our statistical assumptions. But that being said, now in the real world, we're seeing these patients that are letrozole exposed, that need the new therapy. I've been using fulvestrant with the combination. Whether it's fortunately I've been getting it approved. It's not yet. The JCO article came out this year. It's not yet in the NCCN. It should get NCCN listing in October. I just texted Gersh about that this morning, but we should see it. But I think using that with a hormonal backbone makes sense. We're learning more and more. With we're identifying these ESR1 mutations in a lot of these tumors, the estrogen signaling receptor, and in those patients, I didn't realize this. AIs don't work as well as the fulvestrants, so as a degrader. So in those patients, I think if your patient has an ESR1 tumor, whenever you're going to use a hormonal therapy for, you probably should stay away from the AI and use the fulvestrant. But we'll see how that plays out more.
It'd be interesting to actually go back and look.
Yeah.
Or pull out the ESR1 data.
Yeah, definitely. So we have a couple more. I mean, this has been a great session. I like the interaction. Any other thoughts? Or I think we talked about side effects from access. I think the insurance uptake has been pretty good, and we're able to get it pretty easily. So it's just a matter of I think in review for changing the world in low grade, it's educating our colleagues, our pathologists, better identifying these cases, which we are. That are a lot of us don't treat a lot of these, so teaching our colleagues about what we're doing, and then the availability of some of these new drugs is really, we're in unprecedented times. Wendell?
Question about your one on go back, not beating dead old. I just looked at the protocol. The protocol was considered fully mature at 222 past events, but according to this curve, there were only 113 events. But this is not the mature analysis of your.
No, so they met futility though. So that's so it was a futility stop so that they could, yet the trial had fully accrued. In terms of events, the events met futility, so it was stopped. Correct.
So
Correct.
To state that is standard of care based on futility analysis?
I think the room agrees.
Definitely, well, for sure. I mean, and again, you got 11% bump at 12 months. And that's why I was looking at the censoring on eBay, like heavily censor. And it's because it's in 20%, sure.
All right, the horse is dead.
As long as our passion for using non-chemotherapeutic regimens that doesn't go away, I think it's important that we keep pursuing better options for these patients and continue exploiting the options we have. So that's great. That was thanks for attending our session. Jubilee, it's really been always fun with working with Jubilee, and I like the interaction that we had. Here's some of the continuing education required comments for your CME credit. Thanks again to Veristem for their great support of this program and the great support of our patients. Really, it's so important to have that type of availability of the resources that you provide. And this symposium will be available on demand at www.gog.org. So thanks again to Jen and the GOG for making these opportunities available. And we are looking forward to further symposiums, this meeting, and years to come. So thanks for your attention. Thanks, Jubilee.
Okay. Thank you, Brian.